Hi, everyone. So welcome. Good afternoon, good morning, perhaps good evening to some. We're very happy to have you join us today for Alcohol Policy webinar. So this is a webinar series exploring the current state of alcohol policy, public health, and cancer prevention. This webinar series has been organized and presented by the Canadian Partnership Against Cancer, the Canadian Public Health Association, the Canadian Centre on Substance Use and Addictions, and the Canadian Cancer Society. My name is Chelsea Demore, and I work as a knowledge broker at the Canadian Centre on Substance Use and Addiction, and I'm very pleased to be your facilitator for today's session. The COVID-19 pandemic response has brought about significant changes, probably some that are quite unimaginable to most of us. And a lot of these changes have gone beyond just our lives and have kind of bled into alcohol policies and consumptions, trends, and even harms. And because of this, there was a desire to convene professionals and thought leaders in the areas of alcohol policy, public health, and cancer prevention to discuss the current state of alcohol in Canada and policy recommendations moving forward. The purpose of this webinar series is really to renew discussions concerning the regulation of alcohol consumption in Canada, keeping in mind, the effects of the pandemic and moving forward, what might help us. So here's a quick overview of our webinar series. So today's webinar is the second of 4 being offered this fall. Last week, we had our first webinar on alcohol and cancer. Today, we're going to discuss alcohol use, costs, and harms. Next Wednesday, we have a webinar on public health communication approaches to alcohol. And then finally, we're going to wrap things up on Wednesday, November 10th, with our final session on alcohol policy actions. So I encourage you, if you haven't signed up for the next 2 sessions, to please consider doing so. We'd love to have you join those sessions as well. Just a bit of virtual housekeeping before we get things started. All participants have been muted, so we do ask that you use the Q&A feature. So you'll see this on our screen in the bottom right-hand corner of yours. You can pose any questions during the time for the presentation that you might have to our panelists. We do have a moderator on hand who's going to help us organize the questions so we can try to get to as many of them as possible. But keeping in mind that we only have an hour and sometimes we get a lot of questions, we will do our best to answer everyone. Just to note that this meeting is being recorded, but the PowerPoint materials and the webinar recordings will be housed on CPHA's YouTube channel, and all registrants will receive an email when they become available. So if you need to leave for any reason, an emergency, your tech just isn't working, fear not, because there will be a recording for you to go back to once this is all over. If you do experience technical difficulties, including audio or not being able to see the slides, please use either the chat, which you're going to see just to the left of the Q&A box, or you can email webinars@cpha.ca if you're having issues. If you have difficulties hearing today, there is also an option to call in through your phone. So you may disconnect from the webinar and then return back and call in through using your phone. Before we move into the presentation portion of the panel, I'd like to begin with a land acknowledgement. So I'm joining today from the city of Ottawa, and the office of the Canadian Centre on Substance Use and Addiction is also in the National Capital Region. So I'd like to respectfully acknowledge that the city of Ottawa and the offices of the CCSA are located on the traditional unceded territory of the Algonquin Anishinaabe people. The Anishinaabe-Algonquin Nation has been present on and nurturers of this land since time immemorial. We are grateful to have the opportunity to be present in this territory. We acknowledge the Indigenous peoples as traditional knowledge keepers, and that our greater society benefits from the sharing of Indigenous people. Today, each of the regions from which we gather are home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to be present on these lands. We strive for respectful partnerships with all Indigenous peoples as we search for collective healing and true reconciliation. So knowing that some of you may be joining from different parts of the country today, I welcome you to take a few moments to reflect on the land from which you joined today. All right, now I'd like to get things started by introducing our first speaker for today's call. Dr. Samantha King, who is a colleague and close friend of mine, graduated with a degree in neuroscience from Carleton University. Through her work as a research and policy analyst at the CCSA, Sam aims to help close the gap between evidence and practice as it relates to substance use treatment and harm reduction. So I'm now going to turn over the webinar to Dr. King. So you may now unmute yourself, turn on your camera, and you may begin sharing your slides.
Thank you very much, Chelsea, for that wonderful introduction. Are you able to see my slides?
Yes.
Perfect. Thank you so much. Welcome, everyone. I truly appreciate the invitation to speak to you today on alcohol use, costs, and harms. And it's been great to work with each of our partners on this initiative. And I hope that, like Chelsea mentioned, you sign up to attend the remainder of the webinars as well, because they have been very important discussions. So there we go. So today I'm going to be talking to you about a research project that concerns young people and which psychoactive substances are bringing them to the emergency department, with a particular focus on alcohol, given the topic of this webinar series. And while this work focuses on the acute harms associated with excessive alcohol consumption, such patterns of consumption early in life can have consequences and implications for increased lifetime cancer risk. And so I will loop back to this in the discussion, and we can perhaps talk about that more during the panel. So the rationale for the study I'm going to speak to you about today was really from this work that was conducted or released, I should say, in 2018, looking at consultations for youth coming into the emergency department in Sherbrooke, Quebec. And so in this particular study, they looked at all alcohol-related visits to the emergency department for those aged 12 to 24 years of age, from January 1st, 2012 to January 1st, 2017. And they looked at all alcohol-related consultations, including intoxication, injury, violence, and deliberate self-harm. And to verify that alcohol was indeed used, it was confirmed either by the patient, a third party, or a positive blood alcohol concentration. And so some of the key findings from this initial case study were that a hospital visit for an alcohol-related medical emergency occurred every 2 days in the town of Sherbrooke. The average age was 20 years old for both males and females. And about a quarter of these young people that were coming into the emergency department were admitted with a triage code of 1 or 2, meaning their lives were in danger. And only 59% of cases, was a family member or friend contacted following the visit. And so the results of this study were shared widely, both at a national and community level. And it instigated a number of preventive measures and legislative changes to reduce harms to youth after consumption of alcohol. So for the current project, our objectives were to assess what psychoactive substances are bringing young people to the emergency department, to document both the magnitude and severity of these cases across 3 Canadian communities. And given that we know excessive alcohol consumption can cause a number of harms amongst young people, we also have the legalization of cannabis in 2018 and the opioid toxicity crisis, which has been ongoing since 2016, or at least it was declared a public emergency in 2016. So we wanted to look at all 3 of these substances among adolescents and young adults. And we wanted to document the clinical presentation, their clinical and biological characteristics upon admission to the ED, the context within which they're using substances, whether they were co-exposed to other substances, as well as how the patients were managed in the emergency department. And we hope that the results from this study will help to determine priorities about alcohol, cannabis, and opioid prevention programs within the local community. So a little bit on methodology. It was very similar to what was conducted in Sherbrooke previously. We collaborated with a group of clinicians in Saskatoon, again in Sherbrooke, and then in the greater Halifax area. And data were collected from 1 emergency department in Saskatoon, 2 in Sherbrooke, and 4 in the greater Halifax region. And we had a research assistant access and compile retrospective data from all ED visits that involved either of the 3 substances by adolescents 12 to 17 and young adults 18 to 24 between January 1st, 2016 and December 31st, 2019. And for each case, a case report form was filled out, including demographic, contextual information, as well as medical and clinical information. So criteria for inclusion included for each of the 3 substances, an ICD-10 code that could be attributable to that given substance, whether it was the chief complaint or the primary reason they were visiting the hospital, or whether it was a comorbidity. And if an ICD-10 code was not present for a particular substance, if that substance was detected using a tox screen, then that case was included in our sample. So to get into the results, this is showing you all of the in-scope ED consultations across all of the 3 regions. And over the 4-year period, there was a total of 4,635 cases of young people coming into the ED, having consumed either alcohol, cannabis, or opioids. And you can see from the figure on the left that the primary substance reported and across all of these visits was alcohol at 72.1%. Comparatively, we see about 34% reporting having taken cannabis prior to their visit, and 8.2% had taken opioids. And just to note that these numbers reflect, so if someone reported consuming alcohol, that doesn't mean it was the only substance they consumed, but alcohol was definitely involved. And if you look on the right, you can see the trend over the 4-year period for each of the different regions. You can see from towards the end of data collection, so from 2018 to 2019, we saw an increase in the number of in-scope ED visits in Saskatoon and Greater Halifax, but a decline in these cases in Sherbrooke, Quebec. If you look at the age distribution by sex across each of the 3 regions, females are in gray and males are in blue. You can see that for the most part, males outnumbered females, particularly in the older age groups. In Saskatoon, though, in Greater Halifax, you can see that from 13 to about 17, so the younger ages, females tend to outnumber males. This slide is showing age groups broken down by whether the young person was under the minimum legal drinking age to purchase and consume alcohol, or of minimum legal drinking age. And you can see that across all of the 3 regions, you have a greater proportion of cases coming in that were of minimum legal drinking age. And on the right, you're just looking at alcohol-related cases, and this pattern still holds true. So more folks are coming in that are of minimum legal drinking age than are under minimum legal drinking age. In terms of when across the course of the year young people are coming in, the peak periods vary between each of the regions. So adolescents in Sherbrooke tended to present in late June, which often corresponds with when prom is held, whereas young adults presented most often in late March or early April, which is the end of the post-secondary winter term, or during October, which is often considered midterm season. Adolescent visits in Saskatoon were highly variable, but the most common week for visits among young adults was in mid-July. And adolescents in the Greater Halifax area tended to visit the ED in late September, whereas young adults tended to visit in late October. In terms of the primary reason for the young person coming into the emergency department, you can see from this figure that the greatest proportion were there for an unintentional injury, which includes falls, motor vehicle related incidents, as well as cases of violence or assault. This was followed by intentional injury, which includes self-harm behavior of any nature, including both suicide ideation and suicide attempt. And the third most common reason for visiting the ED that was reported by these young folks was an anxiety or mood disturbance, whether that was an anxiety or mood disorder or just an episodic event relating to anxiety or depression, for example. This slide is showing how youth are arriving in the emergency department on the left. So regardless of the region that you look at, you can look at the pink bars, and that shows you that most are coming in by ambulance. So these are not trivial events. They're coming in an emergency situation. And this is supported by the pie charts on the right that are showing you the triage scores. So a triage score of 1 would require resuscitation, and a triage score of 2 is considered emergent or life-threatening, or could be life-threatening. So you can see that a large proportion of these cases, the pink, are emergent. And so these are really serious emergencies. And the trend is similar for those under minimum legal drinking age and those of minimum legal drinking age. And if you look here at just alcohol-related cases by region and year, you can see that the rates of alcohol-related cases were similar in Sherbrooke and Greater Halifax at around 73%. They were somewhat lower in Saskatoon at 44.8%. That said, alcohol was still the most prominent substance reported in Saskatoon. And then if you look at the regions over the 4 years, again, this is just alcohol as a reminder, you can see that there was, again, a bit of an upward trend from 2018 to 2019, except in Sherbrooke, where we see a bit of a decline in that last year. And of all the cases that were coming into the emergency department, 33% had at least one known comorbidity, and between 13.6 and 18.4% had visited the ED in the past for a substance use emergency. So this isn't necessarily, these aren't necessarily isolated visits. These could be young people that need assistance in dealing with their substance use, in particular alcohol. Here we're looking at the Glasgow Coma Scale. So it measures level of consciousness or the degree of loss of consciousness and a number of other factors. But essentially, you're seeing that almost 17% of young people coming in are anywhere, have lost consciousness or could even be in a coma. So there's quite a portion of these cases that are very severe. On the right, you can see highest blood alcohol concentration when it was measured. And the only difference here was that young people of minimum legal drinking age that were coming into the ED in Sherbrooke had a higher blood alcohol concentration than those of the younger age group. So how many substances are these young people consuming? So the figure on the left is showing you that across all of the 3 regions, Sherbrooke, Saskatoon, and Greater Halifax, the majority are reporting having consumed one substance. But if you look at 2, 3, 4, 5, and 6, there are still a great proportion of the sample that are consuming more than one substance, which could have implications for treatment and follow-up. Where the type of alcohol consumed was known, 49.3% consumed spirits, either alone or mixed with other types of alcohol. And for all alcohol-related cases, 28.4% of them consumed alcohol at a bar, pub, or nightclub, 9.5% at home, and 6.8% at a party or event. So these events and outings can really influence alcohol consumption, and we'll talk about that towards the end. So for the final result, I wanted to share who the ED contacted following a visit in our study. So again, this is broken down by those under minimum legal drinking age and those of. And I don't have data for Greater Halifax because they don't actually collect this information on the charts. So you can see that for cases where contact was known, 99% of cases in Sherbrooke were in contact with a family member or friend. And in Saskatoon, of the cases that included this information, only 26% of cases recorded such a contact. So despite the fact that across the last couple of decades, both in Canada and internationally, we have seen declines in drinking among youth, there are still many young people across Canada that are coming to the ED for serious medical emergencies after consuming substances, either one or multiple substances. And across each of the 3 regions we looked at, alcohol does remain the key contributor to these visits among young people. Looking at this community level data allows for identification of local trends to inform prevention and harm reduction efforts specific to each of the regions. And we really noticed while doing this study that data collection practices need to improve to enable a better understanding of some of the context around these visits, what's preceding a visit to the emergency room that is substance related, and what's happening. We need to know more about the outcomes of these young people when they leave the emergency department. As well, there needs to be more consistent data collection on variables that influence equity and diversity. So things like ethnicity or other gender identities. In this set of data, we only report on males and female sex because that's what is on the medical charts, but those practices will need to improve going forward so we can really understand different populations and how these trends are changing. So what does this mean for cancer prevention? So the results from this study really highlight the harms and consequences in young people following alcohol consumption. But we know that early patterns of heavy alcohol consumption in young people can lead to increased lifetime risk of certain types of cancer. So just one example that I'm presenting here, there's high quality evidence that points to increased lifetime risk for the development of breast cancer in women who report consuming multiple drinks in one sitting, which is considered either binge or heavy drinking between onset of puberty and first pregnancy, if obviously relevant. And so any harm reduction efforts or prevention efforts that will help to curb excessive alcohol consumption will also aid in cancer prevention, and all of these efforts should really begin early in life. And then finally, for next steps, we'd like to work with existing partners to raise awareness about the context around such ED visits and implement strategies that may mitigate some of those harms. So for example, following up with the young person once they are discharged to assess their needs, whether that's referring the most complex cases to a psychologist, referring them to an addiction, mental health and addiction treatment center in their community, or even just encouraging the youth to communicate that they did visit the ED with a friend or family member so that they build a network of support in case anything should happen in the future. And we'd also like to conduct a similar study in other cities across Canada to inform the local patterns of use for all of the 3 substances we looked at in this study, including polysubstance use during the COVID-19 pandemic. So you will have noted that our data collection stopped at 2019, but there has been no shortage of reports in the media in the last few months about these wild parties and post-secondary contexts. And with these youth really coming out of isolation and lockdown and starting to socialize again, it'll be really important to support them given the substance use and mental health challenges they're facing as a result of COVID that could have and will have exacerbated pre-existing challenges. And finally, I'd just like to acknowledge all of our collaborators for this study and Dr. Catherine Paradis, who's the project lead at CCSA for this work. Thank you so much.
Thank you, Dr. King, for that very informative presentation. And before I pull up the slides again to move on to our panel portion, we did have a couple questions. So maybe if you would be willing, Dr. King.
Sure.
We did have one question about data. So I believe you noted this, but is there data in your study that separates out youth from underage versus those of legal age?
Yes. So on some of the slides, there are, and we thought this was an important factor to try to determine what if there were differences in the context or the severity of harms between those under drinking age in each of the regions and those of age. So we did break down all of our data by the age groups just to examine that. Yeah.
And then a second question here, more around your methods and the sites you chose. So why were the sites Sherbrooke, Saskatoon, and Greater Halifax chosen for this study? Why did we not seek out other areas? Was there a reason that we chose these locations?
Well, Sherbrooke was for sure a result just as a follow-up to the previous case study that was conducted in that region to see if anything had changed and to look at the data in a little more depth for that region. And then the other collaborations were, I guess, carried out due to existing partnerships with folks in those regions. But we definitely, as I mentioned on the last slide, want to work with other regions and other communities and the emergency departments within them although COVID will present quite a barrier to that, depending on the region we want to look at, because some people are still right in the midst of a fourth wave, and ED physicians may not have time to actually, in fact, they don't have time to spend on data collection at the moment, but we do hope to expand this and scale up to other regions and report on local data trends.
I have a few more questions that have come in actually, so I'm going to keep you a little bit longer.
Sure.
This goes in with your last question around expanding data collection, but someone has asked, how can we support greater area-specific data to support the work?
Can you repeat the question, Chelsea?
So yeah, so they want to know how can they maybe support this research with better data? So we know that data lacks a lot of the times in different areas. So what might be done to get better data?
Yeah, so one of the things we've started doing with our existing partners is to have them take the data to their local communities, whether it's at, a science lunch or another informal gathering, and just spread awareness about these cases and really talk about what's happening, and not just consider these young people that are coming in after excessive alcohol consumption and just sort of saying, oh, just let them sober up and let them get out of here, and then nothing else is done. So raising awareness within both the ED itself will enhance practices within it, but also, spreading awareness in the greater community by sharing this data can sort of open people's eyes to the severity of the issue, and hopefully we can figure out ways to speak to the youth, which I'm sure the panelists will have a lot to say about, in terms of what are the messages they want to hear, and what would help them sort of avoid such circumstances in the future.
And last one before I let you go, was data collected on educational level? For example, do we know if they're in university, college, trade schools? I know we separated by age, but do we have more information around that?
It depends on the region. So it's not complete in that not everyone reported their level of education or what they're currently enrolled in. But for some of the regions, we actually have which school they're attending and what level they're at. So it is something we could explore, but I would say that those variables are incomplete at the moment. So we couldn't provide a full picture, but we do have data on that.
Well, thank you so much, Dr. King. That was excellent. And I think it gives us a good kind of context to start our panelist discussion. So I am going to pull back up my slides here. And perhaps I can maybe get a thumbs up from Sam if she can see these slides, or someone can let me know. Perfect. Okay. So again, thank you so much for that presentation. And now we're going to move into the expert panel portion of the agenda for today. So I have the pleasure of introducing our two guest panelists for this afternoon. So first, we have another Samantha with us today, Dr. Samantha Wells from the Center for Addiction and Mental Health. So Dr. Wells is a senior director and senior scientist with the Institute for Mental Health Policy Research at CAMH, and is also an associate professor in the Clinical Public Health Division of the Dialana School of Public Health, the University of Toronto. Dr. Wells examines the role of alcohol in aggression and aggressive behavior. So thank you, Dr. Wells, for joining us. And our other panelist for this afternoon is Dr. Adam Shirk from the University of Victoria. So Dr. Shirk is a Canadian Institute for Health Research Fellow at the Canadian Institute for Substance Use Research at the University of Victoria. His research focuses on alcohol epidemiology and policy research, and he is an author of the Canadian Substance Use Costs and Harms Project and has contributed to national alcohol harms monitoring systems in Canada, Australia, the US, and New Zealand. And I have the pleasure of working with Dr. Shirk on the cost study project as well at CCSA. So as mentioned earlier, please feel free to use the Q&A feature to pose some questions to our experts. And while we're getting some of those questions queued up and allowing you folks some time to put them in there, I'd love to hear a little bit more from our panelists around your research or interests and maybe how that relates to alcohol policy work. So if you'd like to unmute yourself, maybe we can have Dr. Wells go first with her introduction.
Thank you, Chelsea, and thank you very much. I'm happy to be part of this discussion. I just sort of want to reflect on these really important findings actually, and sort of link them a little bit to some of the work that I've done in the past. As you said, Chelsea, my work revolves around focusing on alcohol and violence. And a lot of that work is focused on male-to-male physical aggression in drinking establishments, and more recently, some work focusing on alcohol and sexual violence, again, in drinking settings, especially bars and clubs. And so a couple of things that really jumped out at me in terms of the findings that Dr. King shared today. One, of course, being that 28% of these incidents were related to, or especially the alcohol-related ones, being at a bar or club prior to the injury. And this is in line with a lot of evidence, and I'm sure Samantha is aware of research conducted by Dr. Sherk, who's done years and years of research on alcohol and injury and violence and presenting into emergency departments in particular. And it certainly confirms, the evidence showing that significant costs associated with alcohol, and particularly acute harms. We know there's a massive literature on alcohol and chronic harms, and I'm sure Adam can speak to a lot of that work as well. But what this evidence shows is that youth in particular are experiencing acute harms and presenting into emergency department settings, and we need to do something about this, obviously. And also, some of these are related to intentional injury, so violence comes into play into this equation, and that's a great concern as well. But it also makes me think about surveillance, and I think some of the questions that we heard already revolve around that. And I think these data tell us we need to be doing more in terms of collection of data in emergency department settings in a standardized way. Because, and as Samantha mentioned, one of the big challenges around this is drawing on the time of clinical staff in emergency settings, which is an incredibly rushed, pressured environment. But we need to somehow collect in a standardized way the role of substances in these acute injuries and harms. But the other big, I think, conclusion from this work is we also need to be doing more in terms of following up these individuals. It's a crucial moment. They've come in with an acute harm, and we're letting them walk out the door without follow-up. What could we be doing to address that? What kind of brief interventions could we be employing to reduce the likelihood that these individuals will return to our emergency department settings with subsequent injuries, but also thinking in terms of the long term of these patterns of drinking, these risky forms of drinking that can actually result in long-term chronic health harms as well, including alcohol dependence, but also chronic health problems. Maybe I'll stop there and let Adam add his points around this as well.
Sure, thanks. Hi, everybody. I'm Adam. Just to say thanks for having me today. Thanks, everyone, for coming. Really excited that this series of webinars is going on. So thanks, everyone, for your participation. Like Chelsea said, I'm Adam Shirk. So I'm a researcher at the Canadian Institute for Substance Use Research, which from now I'll call CSIR, and we're based here at the University of Victoria. And my work focuses kind of largely on two areas. The first is alcohol and substance use epidemiology, and then the second being how do we translate that into alcohol and substance use policy. A little bit about the kind of epidemiological side. So I'm involved in, with Chelsea, Canada's National Substance Use Surveillance System project, which is called the Canadian Substance Use Costs and Harms Project. An ongoing project that's funded by Health Canada, by CSIR, jointly with our partners with Chelsea and CCSA. So that looks at 8 different substances, a big focus on alcohol because that's the most costly in terms of the societal costs of substances in society. And then, like Chelsea said, I've also worked on alcohol harms monitoring in different countries around the world, in New Zealand and with the US CDC, with our neighbors to the south in Australia, things like that. And then in terms of translating those results for monitoring and surveillance into policy, our shop here at CSIR has a strong focus in the population level policy. So it'll be good on this panel with Samantha. She has a lot more knowledge on the individual level side. And our shop is working a lot in population health level policies like pricing, like availability, like I still think education has a big role to play in terms of alcohol, particularly if we think about, let's say, the alcohol cancer link, which is the main focus of this webinar series. Still less than half of all Canadians know that alcohol even causes cancer in the first place. And here, alcohol-caused cancer is one of the leading causes of death among all the deaths that alcohol is responsible for. So there's still a large role for education to play. There's a lot of gaps, like low-hanging fruit, you know, that we can kind of harvest as we go forward.
Well, that's great. And thank you so much for sharing a bit more about both of you, your work and your interests. And it's clear you're very knowledgeable and passionate. So we're very happy to have you on our panel today. I want to open up with a question around surveillance. And this came from one of someone who signed up for the webinar, and they wanted to know, what are the most pressing data gaps in surveillance? And maybe, I don't know if Adam, if you want to start, and then Samantha, you can kind of jump onto that, but what are the major pressing sort of gaps? And I'd like to know if there are what are the barriers around getting to those gaps?
Yeah, it's a great question. I thought a bit about this before. So first, I'll flip the question around. And I'll say that Canada actually has very strong substance use surveillance in a global perspective. So other countries just don't have systems that enumerate costs and harms on a national and provincial level, particularly ongoing studies. It's very rare, especially across like many different types of substance and many different harm outcomes and cost outcomes. Sometimes nations will take this on as a one-off, but to have an ongoing study like that is a very strong asset that we have in Canada. That said, though, there are definitely gaps. And so I think probably the most pressing gap, as I was thinking about this, is, and it ties into some of the other questions as well, is equity lenses in surveillance. So a lot of this is built from administrative data. Often we have things like age and gender. Gender is an important equity lens, but it doesn't get into things like education, other dimensions of socioeconomic status like income. Those are really important for surveillance, especially because people of lower SES, let's say income, experience a much higher kind of impact of each alcohol unit used. So that's an important thing moving forward. We can think about how to improve kind of our data systems in Canada to begin to capture that.
Sam, did you want to add anything there?
Yeah, well, I'd like to, I completely agree with Adam, and I think focusing on equity and diversity is really important. And so we could be doing more in terms of drilling down into certain marginalized, racialized groups in terms of understanding mental health, but also substance use challenges. And that's actually one thing the reason I'm adding mental health to the picture is I think it's really important to look at linkages across all of these mental health challenges, and addiction being part of that umbrella. So to me, For example, here's an example. When you think about the impact of the pandemic on all of us right now, and thinking about Dr. King's work on her presentation today, these are pre-pandemic data. We need to be thinking about the mental health of youth, young adults, the stress associated with the pandemic, the financial pressures of COVID, and how these are in turn impacting substance use issues, particularly alcohol use. And so to me, in terms of surveillance, we need to sort of think back to a broader scope, not just looking at substance use, but looking at a range of issues that affect substance use across all populations. So considering diversity of those populations. I also think we need to do more in terms of administrative health data. A perfect example, of course, is Ontario, where we have the Institute for Clinical and Evaluative Sciences, where we actually systematically collect administrative health data, including hospitalizations, emergency department visits. But that's only in one province. We should be doing that across the country. I also think, and I know other provinces do this, have similar models, but I think that, and linking administrative health data to self-report data, I think we need to do more of that. And I think looking more systematically in terms of alcohol sales data across the country. Are there ways of combining all of these sources of data and looking at them across, systematically across all levels? I'm even thinking about police data as well. To me, we should be combining all of these sources of data together and housing them perhaps under one roof and really drilling down even to terms of spatial analyses, geographic analyses. I think there's a lot more we could be doing in terms of surveillance. And finally, in terms of, just to sort of reiterate what I said before, in terms of Dr. King's research, doing more in emergency department settings. I think we could certainly be doing that. So those are my comments. Thank you.
Yeah. Well, we know that intersectionality and sort of those intersections of all of those factors is so very important when we talk about substance use and mental health and the co-occurrence of those two things. I want to chat a little bit about, so you talked about pricing, and we actually got a very interesting question that I think really kind of gets at what we're talking about today. So they had kind of mentioned about how young people really tend to gravitate towards those spirits, those like sugary alcohol drinks, and how they tend to be priced at the lower end of the spectrum. Have we seen sort of any provinces that have prioritized pricing of alcohol content or the way that they sell things that has actually reduced harm, maybe for youth or other individuals? And if we haven't done that yet, are there things we could do?
I'm happy to start. So some but not all provinces have facsimiles of what's called a minimum unit price or a price per drink. So this is about setting a floor price on ethanol, the pure alcohol in our drinks, so that alcohol can't be sold at a level that's really cheap. Some provinces have things that are quite similar to this. In Saskatchewan, in Manitoba. I'm happy to report that BC is doing a consultation right now on possibly implementing a minimum unit price. Something like an MUP has recently been implemented in Scotland, in Wales. So it's gathering some momentum internationally, which is necessary. Sometimes, and anecdotally as well, when I was younger, people especially, students, youth, people are searching out bang for the buck products. We were searching out the highest strength, the most ethanol per dollar. It's just known. You'd buy the beer that's 5.5% instead of 5. It's the same price, but you get 10% more, this sort of thing. And so we really need floor prices that that are tied to the ethanol in the drink, that will help. It will in some ways, limit the amount of ethanol that can be purchased if you think about kind of money as a limiter. Now, there are important equity consequences on that side too that need to be addressed, to be thought through. But the possibilities for improving population health by implementing a minimum unit price are very large. So I think that's kind of the most important and promising pricing measure that provinces, or that it could be, potentially it could be done federally, could look at implementing in Canada.
I want to keep on this question if we don't mind, because there's kind of a follow-up, and then I want to get into talking to young people because I think it's a good segue. So this question here is, what impacts would we see in the proportion of young drinkers if the minimum legal drinking age was raised? So I think a lot of folks, and maybe this is a contradiction, right? Like, we raise the legal drinking age, maybe young people will be less likely to consume in heavy quantities. What are your thoughts on that?
Do you want to take that, Adam?
Yeah, sure. No, I'm happy to start out. My colleague here at CSER, Russ Callahan, has done a lot of work in Canada on the minimum legal drinking age. And it's, I guess, just thinking about it, I wouldn't really expect it to really matter that much. I would just kind of think that people, when you're that age, you just kind of drink if you want, and you're not really thinking about the legality of it. But it does deter people from drinking more. So his work has generally found that there's an increase in harms once people cross that threshold above the MLDA. So there is evidence that the harms would be reduced by increasing the MLDA. Do you want to go, Dr. Wells?
No, and I just, I think that there is evidence in the US, that I think age of onset is really important, actually, and we know that. The evidence shows that the earlier people start to drink, the more likely they're going to drink larger amounts per occasion and develop substance use challenges and so on. So age of onset is really important. I think there is a lot of controversy about, the drinking age, and I think it would be tough to make a big policy change like that. But certainly there is some evidence to show that a higher drinking age would result in later drinking and fewer harms. But I did want to go back to the topic of the previous question relating to products that are targeting youth. I think we need to think more about that. And it's not just the minimum pricing, it's the packaging, it's these sugary drinks that, almost taste like a, lemonade or whatever. There's so many products out there now on the market that really are targeting young people, much like cigarettes, where there are certain products that are targeting young people with certain flavors, and then now we're seeing it with vaping. There's clearly the industry is targeting a certain demographic, and we need to really be thinking more about regulation in these spaces to prevent people starting to drink these substances excessively.
If I could just add 2 points that I kind of thought of as that was being discussed. The first is about the minimum legal drinking age again. I noticed on Dr. King's slides, and I thought this was so interesting, that so it seemed like people that were above the minimum legal drinking age were more likely to be brought to the emergency department via ambulance. And so that says to me that people below the MLDA, they're deterred from calling an ambulance to get the help that they need because of this, the legality of it. So on the other side, that is not good. We don't want people thinking they're going to get in trouble, for calling an ambulance when it's necessary. The difference was quite large. It stood out to me right away. So that would be something that we'd have to think through if we were to move on changing the MLDAs. And then to build on what Dr. Wells was saying, and because this is an alcohol policy series, something that's also important, probably for me right up there with pricing, is labeling. We really need to move forward on alcohol labeling. The alcohol beverage labeling in Canada is, the regulations are non-existent. Nothing needs to be put on there at all. Alcohol products are specifically exempt from having nutritional information. Like, compare, both of them have a very strong link with cancer and cause a huge cancer load in Canada. But think about the packaging on a pack of cigarettes compared to a bottle of wine. On one we have like a cancerous tumor, and on the other, like a pastoral agricultural setting of a vineyard. And that, really doesn't make a lot of sense to me as someone that works in public health. I think labeling needs to move forward a lot, and that's a policy that, again, could kind of be worked on at either the federal or provincial levels.
And comparatively, I mean, we have lots of risk labeling on cannabis packaging as well, and the risks are nowhere near as substantial in the costs and the harms to alcohol, and we're able to move forward with that, and perhaps we can take a little bit from that approach as well. So if it's okay, I'd like to kind of pivot a little bit and talk about prevention and education, because I think that's a really important part to speak about, especially with young people. And one of the questions we got upon registration gets at sort of this alcohol and cancer link, and how do we get young people who are 18, 19 to think about how their actions today can increase their risk of cancer later in life. And sometimes it's not even that much later in life. It could be 20 years, but it could be 40 years. How do we communicate with young people, especially when a university campus, let's say, where it's so entrenched in their the community and what they do? How do we communicate that with them? And I'd love to hear from Dr. Wells first on this one.
Sure. I think one of the problems, I think, sometimes is that these messages sometimes don't work. The educational tools that we use don't work with young people in particular. So coming into a school and saying these drugs are bad or alcohol is a problem. I think we need to think more innovatively about how we communicate with young people. And I think we need to engage them more in a conversation rather than lecturing them. I think that just handing out pieces of sheets of paper with an information sheet on the harms, I don't think that's going to work. I think we need to have conversations with young people. We need to hear from them what kinds of communication work best for them, given this social media world that we're living in, and combat some of the messages they're hearing over social media. So I really do think some of the education also has to be giving them skills rather than just educating them. We need to actually have skill-based programming. So discussions, but also how do you combat somebody? How do you actually, when you receive pressures from peers, when you receive all of these messages suggesting that, we should be engaging in heavy episodic drinking, for example, how do you respond to those pressures? What do you do? But also we need to adjust some of their perceptions around norms. So there's been some evidence to show that young adults often perceive that their peers are drinking more than they really are. So we need to sort of correct those norms. But I think it has to be more. There has to be more engagement. There has to be a conversation, and it has to be skill-based. So those are a few remarks on my side. I'd be interested in hearing what Adam has to say.
I think those are great points. I completely agree with everything that you said. That we need to be innovative, particularly in communicating with young people. I would say that the first step in communicating with young people is just do it, because it's not getting done a lot. So we can definitely try to particularly about the chronic harms that people will develop over their life course. This just isn't done a lot with young people, you know, like I didn't even know until I started as an alcohol researcher that alcohol causes cancer. And so like the most important step is to try to do it. And then we can try to refine the best communication techniques to do that with young people. Another thing, to go back to the labeling, because I think it's so key, labeling is kind of a type of education and communication policy. And it's key because whenever you're going to have an alcoholic beverage, you're going to have this chance to be educated, is too like highbrow a term, but you know, like it's right there. If there's health warnings on the package, you're touching these packages every time unless you're getting the drink in a restaurant or something like that. That's so key. So health warnings as kind of educational tools that we put on alcohol products, just like there are warnings on all other products really that I can think of other than alcohol. So that's a really important piece too.
I just would like to add another thing. You know, to me, there are moments when we have opportunities to communicate the risks associated with alcohol, such as in primary care settings. You know, a conversation with a young adult in primary care, simply, oh, you know, and are you drinking alcohol? Oh, how much do you usually drink? Just a few tidbits of information here. It's important that you know that it's linked to cancer, and here's some information. So, you know, so having that expertise from a medical professional, I think is important. And again, this could be happening in emergency department settings, but it could be happening in primary care, but it could also be happening in counseling settings on campus and universities when young people seek help. We need to think more holistically about when a person comes forward with stress or anxiety, oh, are they using substances? Having a conversation about that. We need to think more about substance use in a variety of settings and have an opportunity to have a conversation with young people about the harms associated with alcohol, both in the acute harms and long-term.
I have a couple quick questions before we wrap up. Adam, who is in charge of alcohol labeling? So is that Health Canada? Who does that?
So the nutrition facts label, which is the black and white label, like, because I did some work on this, that's done by what is it called? It's not Health Canada, but it's like food and beverages. I can't quite remember offhand, but there's a specific, if you read through their regulations, which are pretty easy to find, everything has to have a nutrition facts label on it, even bottled water, which has no nutritional value. But then there's like even non-alcoholic beer, you know, has to have a nutrition facts label on it. But then there's a specific thing in the regs that says alcoholic beverages above 0.5% ABV are exempt, you know, so they just get a complete free pass on the nutrition facts. And then like another piece that we really need, and this goes to Samantha, Dr. Wells's point about products targeted at youth, is information regarding how many units, how many drinks of alcohol are in each container. You know, like if you buy one of those cans of, it's called fucked up or, you know, whatever, I don't need to pick on one label. There's like 4 drinks in that one can. You know, so if you're not like taking out your calculator and multiplying the ethanol percentage by how big the product is, you might not realize how potent those are. Like to have 2 cans, most people would say I had 2 drinks, but really that person had 8. And that is, needless to say, a very big difference.
You know, and another thing to this is a lot of the products now are targeting people in terms of being low in sugar, you know, and that's, you know, so they're perceiving like, oh, this is a low sugar product, this will be healthier. And again, we need to sort of, you know, if we have that kind of labeling on products, we also need to show people what the harms are as well.
And I think that goes back to, again, we need to be speaking to the people we're making these for. We can't make assumptions about what young people know or what people who use drugs or alcohol know. We need to engage them in that process. And so I think that really speaks to, you know, bringing voices into policy, asking people what they need and what they know. All right, so we are at the end of our time. I'm so shocked. These always go by so quickly. We had so many great questions, and apologies that we couldn't get to all of them today, but hopefully we got to, you know, enough that it gives you what you needed from this session. So you will be redirected automatically to a short evaluation survey after the session is done. We do ask that you please take a few moments to complete the survey and provide your feedback. It only takes like 3 minutes. We've timed it, and your responses are incredibly helpful in planning future events. So thank you so much to our panelists, to our participants. We couldn't have had a great session without you and your questions, and we hope to see you in our next session next week. Take care, everyone.